Richard, over to you. Now, I know Richard's work for many, many years, particularly when he was involved in primary care. He said, don't put me in the primary care box, because when the last 10 years I've been a lot more hospital care. But he is a legend in the world of quality improvement, and we look forward to hearing your talk about the registries in the Netherlands.
Thank you very much. I'm not going to talk about my looks. I'm going directly to the situation in the Netherlands. I started my presentation with a kind of statement that effective quality improvement needs measuring, and measuring again. You need data, and data more or less are a holy grail in the process of quality improvement. So where are we now in Holland? I will speak briefly about that, and then I will go into to see if I can take the issue a little bit further, and then not so much giving you all kind of data of what already have been achieved, but mostly questions and challenges. A little bit about the let's say the last decade, the last 5 years. Maybe some of you have heard yesterday something about data that are collected by the inspectorate. There's a well-running process in the Netherlands, but there's also some other processes in the Netherlands. For instance, data collection on hospitals for public reporting. And this has been a target in around 2007. Mostly top-down driven. It's a governmental approach this was, and the aim was that in the end we would have about 80 different conditions, that we would have beautiful sets of indicators and data. We are now in 2013. We have difficulty in getting data for 40 different conditions, and this raises a lot of problems. You see that a number of the issues that we have discussed in the last years, for instance, many people have all the time doubts about the reliability and validity of the data. People have conflicting views about them, conflicting interests. The professionals have the feeling that they do not own the data, they don't spend much energy on collecting them. The biggest problem actually experienced in the front line is that all the stacking of different data sets you have to do for different stakeholders. I'm on the board of trustees of a big hospital in the Netherlands, and they explained to me that annually they need to collect data for different stakeholders on 1,500 indicators, different indicators. So that's really a terrible situation for people who have to do it. So, and on the other side, the insurers who have to buy the care, they say, we can't wait anymore till we get good data and start collecting data on their own. So, an unfavorable situation. So, one of the answers to this problem, as thought by many, is going into the direction of professionally driven clinical registries. And we have some very good examples, and I'm not going into that. Later you will hear about the situation in Sweden, so we have some evidence that this can help to drive better outcomes and lower cost. In the Netherlands we have, I think, about 20 different clinical registries. Some very good, very successful. I show you a very successful one. That's the National Clinical Registry on colon and rectum cancer surgery. And the data are a little bit small. It's running now for a number of years, 3-4 years. Almost all the hospitals that do cancer research on the colon and rectum participate. And what you see is a trend. It's not very stable yet. There's a trend of lower mortality rates, for instance. If you go and look at the other registries, then a kind of general picture comes out of that. For instance, we have a fantastic intensive care registration, also leading to better care. But there's also some problems. So, if you summarize the lessons on clinical registries in the Netherlands, I have a few points to make. First of all, the good thing of these registries is that they are professionally driven. So most of the time they are really supported by most of the clinicians, so they have a basis there. The other thing is that here and there you can see very good pockets of improvement on professional performance. The downside is that most of these registries only cover a very small part, defined part of the whole care provision pathway. So only a part of, for instance, surgery on cancer, not primary care, hospital care, primary care, rehabilitation, etc. Most of the time these registries are not really stimulation, better coordination of care or collaboration between disciplines. Maybe they even hinder it. We see now, just like in Sweden, a variety of registries that are of different qualities. There's no coordination, there's no collaboration between the different registries, no one overseeing them. There's limited scientific development, and maybe most of all, they are most of the time not public. The data are not publicly reported. So the question is this the way to go? So I'm speaking here today on behalf of the Dutch Federation of University Medical Centers. This federation doesn't want to develop their own registries, but would like to help create innovative models for quality registries in the future. And what do we mean by that? If you look at the model for the future, what do we really would like to see? First of all, we would like to see measuring quality in the complete multidisciplinary care pathway. We would like to see patient-reported outcome measures integrated in the care process and then helping to drive improvement. We would like, and we know that this is very difficult, we would like to see a combination of indicators that are useful both for, first of all, for internal quality improvement, for professionals themselves, and also for external accountability. We would like to see it initiated and led by professionals with defined ownership, but then in multidisciplinary collaboration. And we would like to see a focus on benchmarks, sharing best practices, and these registry as part of a process of continuous quality improvement. So that's the ideal. What you need for that is that you can't do with, like many of these registries have, with 50 to 100 different indicators. You need a core set. You need a limited set of indicators that cover this multidisciplinary pathway. What you also need is feedback real time. So you need monitoring, prospective monitoring, with very quick understanding what you have done. And what I said, this set of indicators should be usable by different parties, which is a difficult element, but you need to prevent this stacking of data collection. Feedback, benchmark, quality improvement possible, a small balanced set of crucial process and outcome indicators. And I mentioned a number of things here. So this balanced set should relate to volume, indications, access, but most of all, clinical outcomes and things that really value for patients. I give you an example of how people struggle with that, because this is really a struggle. This comes from, I'm from the University Medical Center in Nijmegen University, and there's a cancer center, and the cancer center in the last years has developed very strictly defined care pathways, and this is not primary care, this is just only the hospital, but it's the whole care pathway for 12 tumor types. And what they did then was developing a kind of generic indicators for outcomes and processes. You see here some of the outcomes. And the interesting thing is, because this is, I think, quite obvious, 30-day mortality, re-intervention after complications, readmissions after side effect of chemotherapy, etc. But the interesting thing is not so much, because we don't have we have some comparison data, national data. But the interesting thing is, and that's driving improvement at the moment, that between the different groups, tumors, there is a large range of outcomes. And people see that, and they discuss that. And this is the starting point of improvement activities at the moment. I give you another example from my own university medical hospital, and this is about stroke. The interesting thing is there that they started some years ago with collecting data. This is a small set of data. It's only 9 or 10 indicators. This is such a core set. And they can compare it with national data. But the interesting thing is that when they started, they were one of the worst stroke services in the country, and you see from the data now that they are one of the best if you compare them in terms of door-to-needle time, length of stay, thrombolysis, home after 3 months, also something that matters for patient, home after 3 months. So you see that this data has driven internal quality improvement, and they are now using this for external comparison and accountability. Okay, how are we going to do this? As I said, there are projects initiated now by the Federation of University Medical Centers with the goal developing new models of quality registries for multidisciplinary care pathways meeting all these criteria. And we do this by bringing together all the expertise we have in all the universities and academic medical centers, because we need that. They need to do the research around it, and they need to test the new models. And the other thing we do is setting up experiments with the new registries in regional networks between academic hospitals, teaching hospitals, other type of hospitals, primary care practices. So we have just selected a number of issues, and we hope to start within a few weeks with stroke and head and neck cancer, and some other issues, some other topics will come later, rheumatoid arthritis, Parkinson, and COPD. And quite crucial is this, that we say all these projects need to go very rigorously, methodically through this process that is on this slide. First of all, looking again at the multidisciplinary care pathway, coming to a very good definition of that. Then for that pathway, defining the quality indicators, this core set, this limited set, and then some of the most difficult things, describe exactly the process of data collection. Who is collecting what at what moment in this process? Yeah, and where to get the data, and how can ICT help you in that, electronic patient record, and what other type of data sources do you need at what moment in time? And we are aware that this is the most difficult part. What also is difficult is developing the right effective feedback reports for the specific audiences we would like to reach. And finally, you need to develop a system with ownership of the professionals, but you need to continuously further develop the system, validate the indicators. I'm going to go to my last slides. Yeah. I would like to end with a few dilemmas, and these are more questions, and maybe you will discuss that later. We don't have much time to discuss that, but these are really questions for us. So what exactly is a core set of indicators? How much outcome, how much process in that? What's really important for different parties? We have also a very important question, that is, what you see is, it's not necessary for every specific condition to develop specific indicators. For instance, for cancer, for different cancer types, you can develop generic indicators, but how much generic and how much specific? What's the balance, exact balance between internal and external use? And I would like to focus you on this paper. This was in the BMJ Quality and Safety Journal, and has been written by a team of people I think really understand something of the complexity of this issue. It's a team of leading figures in the United States, and what they actually say is how to get this balance between process, outcome, outside, inside. And one of the interesting things, I'm not going to discuss this article, but what they say, and this is also my experience, in most hospitals at the moment, when we collect data, 80% is for outside, 20% is for inside. And they say 30% should be for outside, external accountability. 70% should be internally driven for your own quality improvement for your patients. So it's a very strong message. And then the last questions I have is how to organize this prospective data collection, which you integrate in a normal clinical process. How to integrate patient-reported outcome measures within the normal clinical process and then using them for accountability. How to develop models and formats for feedback where you can report that and stimulate how to use data for continuous improvement of patient care. What methods are you going to use for that? And finally, long-term funding of registries, because we see now that the different registries in the Netherlands need to be paid by hospitals themselves, and they say we can't pay millions per year for different registries. This is my message. Thank you very much.
Thank you very much, Richard, for the wisdom of your years of involvement in quality improvement. That was, I mean, it just made so much sense. It really was really clear. And Robin, I don't know what you think in terms of, I mean, my experience of the UK registries is they've all developed so separately. This idea of getting core quality measures in a multidisciplinary context seems pretty essential.
Yeah. No, absolutely, and but it's also one of the major struggles. And the good thing is that we have examples, and the problem is that if you have a quite complicated condition with many players in the care process, you will have this discussion because every discipline says this is absolutely necessary. And what you see then in the registries, for instance, this registry with on colon and rectum cancer contains about 80 indicators, and they need to downsize that over time, but this is a real struggle. So you need to work on this with all parties to come down to this core set of indicators.
Thank you very much. We'll move on at this stage now.